We're getting near the end here at the AATS Mitral Conclave 2015, but we saved the best for last. Isn't that right? That's what you told
Absolutely.
me to say. That's what you said. So I'm joined by Pat McCarthy. You know Pat, all of you know Pat. He's from Chicago Northwestern. And my good friend Hugo Vanerman. You're my good friend too. Hugo Vanerman from Brussels in Belgium. Thanks for joining us.
Thanks for having us.
So you guys were talking earlier, and I think it's an interesting thing. Again, this sort of approach, how do you approach the valve, okay? How do you approach the repair process? So we've got a male, 65-year-old male, could be a female with severe MR, Barlow's, big bileaflet prolapse. You do a midline sternotomy? Do you do a minimally invasive approach, minimal access? What do you think? Hugo?
What I think is that we should be prepared to have the entire armamentarium, because we are not the gatekeepers. Cardiologists are the gatekeepers. More and more guys are so keen on doing stuff on the mitral valve with a catheter. And I think you're in the conversation that is going to go on. If we want the notion heart team to be reality and not a myth, we have to be partners them, and we have to be able to say, listen, okay guys, you do a mitral clip on a Barlow, we can fix it afterwards. We can fix it minimally invasively. And of course, we can only talk that way if we talk about huge centers with a lot of mitral valves with big volumes. And in a huge center where they've made the move towards minimally invasive stuff, when it comes to the mitral valve, they do as good a job as through sternotomy. I think it's not about marketing, it's about becoming a better partner with your interventional cardiologist.
That's an interesting point. Pat, I look at it as, I'm thinking a little different. I hear what you're saying. I'm thinking about durability of repair, outstanding repair, and I think historically, if you do a classic sternotomy, it doesn't have to be a full sternotomy, you do something. Is that?
Well, so my role in this, I told David this is my third time debating and being the one to defend the full sternotomy as if I'm some guy who cannot evolve and has not, grown any better. So I told him I'll never do this debate again, first of all. But second, it's really to defend, this is a safe operation, it's effective. What we really want to make sure is that surgeons that aren't doing a lot of mitral surgery probably shouldn't be doing some of the less invasive approaches and robotics, and that the data with full sternotomies is actually good. There aren't very many sternal wound infections, there aren't dehiscences very often. You can do everything through there. And so if the patient needs an aortic valve, needs coronary bypass, it's easy to add a tricuspid. So it's in the comfort zone of all surgeons. And so it's just a little bit of, we don't want people to leave their comfort zone to go do something that is not as safe or effective for the patient.
Is this, is the minimal approach that you would do on a patient, is that effective and safe?
It is.
It is with Hugo.
That's exactly.
There's no doubt that it is. I would never, ever do another action on a patient if I would be convinced that it would be a suboptimal result, or if I would add risk. That is not ethical.
But where I was going, and Pat answered it, it is if it's with you. So you're very experienced, you know when to do what and when not to do what. But I think he makes a valid point. But it could be valid in an open sternotomy, but a minimally experienced mitral surgeon should probably not do minimally invasive
I
minimal
agree.
access.
If you're in a center where you do 25 mitral valve repairs a year, stick to your comfort zone, because you don't have enough load to go out of your comfort zone.
What can't you do through a minimal access that Pat can do through a larger access?
I almost do everything, apart from some occasions where, for example, there's a lot of calcium. The shafted instruments are inappropriate to take care of calcium. If there are big blocks of calcium.
Calcified annulus.
Calcified annulus.
Okay.
But would you send a patient with a calcified annulus to a guy who does 25 mitral valves a year? I don't think so.
No. So that's the one that's one of the things you can't do or don't feel comfortable doing. So Pat, go ahead. I'm sorry.
So I think the interesting thing is that both Hugo and I ended our lectures the same way, even though we started from supposedly different points. And I ended mine by saying that if they're going to learn a new set of techniques, be it robotics, all the minimally invasive equipment, what they might want to be thinking about is instead learning a set of techniques that are wire skills, so that there's more and more surgeons that are now the operating people for MitraClip. There's going to be transcatheter mitral valve replacement coming, and so people can stay engaged and stay up to date and doing new things, but if they're not doing very much in the way of mitral valve repair, they may not want to be the ones that are adding on the complexity of doing it minimally invasive. Hugo and many others can do that operation great and get great results. But across the board, that's not always true, and that's also not always true with full sternotomy.
Have you learned anything at the meeting besides it's a lot of talks?
A lot of cool technologies coming and stuff. I mean, this is like TAVR 10 years ago.
Absolutely.
A lot of the stuff is just beginning.
You said it all, Pat. You know, Mike wrote this editorial a couple of years ago. Fool me once, shame on you. Fool me twice, shame on me. We're going to be fooled a third time, double shame on us, because we haven't understood that PCI was going to take off and decrease the numbers of coronary revascularizations. 10 years ago, the course directors of the Master Valve Repair were told Edwards bought PVI. And everybody was laughing. It's like, oh guys, why are you laughing?
Right.
They're not laughing now.
They're not laughing now.
No.
Same thing is going on with the mitral valve. Francisco, he took the right decision. He's a surgeon. 10 years ago, he thought there's going to be is going to need hybrid skills somewhere.
No,
and he went to the
that's a
cath lab.
good point. Let's finish up. So, Pat, I know Hugo knows this, but I'm sure you have patients come to you all the time, because I hear it all the time.
Sure.
You know, you're not going to give me a big scar, are you? Can't you fix this with a little bitty incision or through a robot or do something like that?
I tell my patients I want to do what's the safest operation and the most efficacious for them. And I tell them I don't do that old 20-year-old incision. I said, but I do an incision about like that in most patients, but put it in the middle is typically what I do. And over the course of my career, I've done the right thoracotomies and heart port and minimally invasive. And I work with my partner now who does also do right thoracotomies and do minimally invasive. So we do all of it.
And Hugo, that's not, obviously with your approach, that's not a problem with patients. But when you explain to the patient how you're going to approach them, or they say, ooh, I like that better than...
It's amazing, Randy, if patients come to see me, they've read more about less invasive access than I could ever have written on it. And they've been to all sort of websites, blog spots, testimonials, etc., and they come to tell me they know everything. That is amazing. There's a great deal of patients now, they Google, I have mitral valve insufficiency, and I want a small incision, bang, and then they work all night.
Absolutely. No,
The patients are very educated. They show up and they will tell me what kind of heart valve they want. They tell me what model number it is. Like, I have to look up what model number that is.
It's amazing. Well, you both started with an interesting point. So, and that was the point about the future surgeons, what the surgeon of the future has to do. And I think it's really important. But nothing surpasses quality and excellent outcomes. And you both have stood for that. So thanks very much for joining us.
Thanks for asking us.
Welcome, Randy.
Good.